Okay, Jenna and I had toxic epidermal necrolysis, which can also be called TEN.
So, what is toxic epidermal necrolysis? Toxic epidermal necrolysis is a rare skin disorder that presents by a blistering and peeling of the skin. This disorder can be very life-threatening. Toxic epidermal necrolysis disorder is typically caused by a reaction to a medication, and in most cases, the reaction is from antibiotics. So, clinical presentation and symptoms. So, we can see peeling skin, painful and red area that spreads quickly, raw areas of skin, discomfort, fever, pain, and it can spread to the eyes, mouth, throat, genitals, urethra, and anus. Toxic epidermal necrolysis causes the skin to peel in large sheets, as you can see on the screen in the pictures. This leaves raw areas of exposed skin. The loss of skin allows fluids and salts to ooze from the damaged areas, and this is bad because raw skin is very easily infected and can cause many major issues to come in the future. The symptoms of toxic epidermal necrolysis can resemble other skin conditions. This is a life-threatening condition, so it is very important to get any skin abnormalities checked out before they get too severe.
Alright, so the first organ that you'll see TEN is in the skin, and it will cause blisters and peeling, and it typically starts on the chest and the face. Next, it will spread to the mucous membranes that are located on organs, and especially in the mouth and airways, which makes it really hard for these patients to breathe and to swallow. Next, it'll spread to the eyes, where it causes irritation and redness. And then it typically will spread to the genitals and the urinary tract, which will cause painful blistering. But if it's left untreated, it can lead to shock, sepsis, multiple organ failure, and even death. So the progression of the disease, it usually starts as a reaction to drug that can be typically treating a respiratory infection. So it starts as a flu-like symptoms such as fever, sore throat, burning eyes, and fatigue. And then, if it's not treated, it will lead to Stevens-Johnson syndrome, which is a painful rash that spreads and blisters and the dead skin sheds. And then still, if it's not treated, it will become even more severe, and it'll spread to more areas of the skin and more organs, and then it needs to be at least on 30% of the skin to be qualified as TEN. And then if it's still untreated, it can cause pneumonia, sepsis, shock, organ failure, and death. So Stevens-Johnson syndrome and toxic necrolysis syndrome are on a continual spectrum. Stevens-Johnson syndrome is just the less severe form of TEN. They first used to be considered two different illnesses.
So, prognosis. For the fatality rates, adults are about 25%. Elderly is greater than 25% because they're more susceptible to these illnesses. And then children is under 10%. And then for Stevens-Johnson syndrome, of all ages, it's about 10%. And recovery can take weeks to months if not fatal. So, modifying conditions. So there's pre-infection. Redness of the skin is one of the very first signs of toxic epidermal necrolysis. And then we have co-infection. So toxic epidermal necrolysis at its peak can be very life-threatening and very detrimental. So for the pre-infection, patients may notice slight redness that spreads quickly. This is normally one of the first signs of infection, but oftentimes goes untreated because people do not realize or know that they needed to get it checked out. And then co-infection, toxic epidermal necrolysis during infection can be quite painful, and symptoms start showing up including widespread skin pain, a spreading rash covering more than 30% of the body, blistering over large areas, peeling skin, sores, swelling, and crusting of the mucous membranes, including mouth, eyes, and vagina. Then we have post-infection, where sequelae is a pathological condition resulting from a prior disease, injury, or attack. So there's ocular sequelae, which leads to blindness. Meanwhile, the mucocutaneous sequelae can alter the functional and social prognosis. So there's mild, moderate, and severe of this. And this picture is right there. That's the ocular sequelae. And yeah, so sequelae are most are common features of late phase of 10. So after it goes untreated for so long, this can happen, and then the mucocutaneous sequelae can happen.
Okay, so then we're going to move into Mycoplasma pneumoniae. Its classification is mollicutes. It includes bacterial pathogens found in many animals and plants. And a description of this bacteria, it's the smallest self-replicating prokaryote known to cause infection in humans. It also lacks a cell wall, which makes it resistant to penicillins and cephalosporins. It also has circular double-stranded DNA. Growth conditions are humans are the only known natural host for this bacteria, and if you're trying to grow it in the lab, they have very high nutritional demands and need a pH of 7.8 to 8, so they're very difficult to just grow in a lab. And the life cycle, they produce by binary fission. It spreads from person to person by contact through respiratory droplets, and they grow very slowly. And they typically cause respiratory infections. Okay, some more unique characteristics is, like we said, they're the smallest organism capable of living and reproducing on their own. And they also do not have a cell wall, which means they're able to alter their size and shape to suit its environment, so they're very adaptable. And they have evolved and have grown a special attachment organelle that allows them to attach to respiratory epithelial cells. So they're very difficult to treat. And then the host response when they become infected to this bacteria. Once the bacteria attach to cells, they trigger the innate immune response and produce a local cytotoxic effect. Symptoms usually appear after 1 to 4 weeks, and they most commonly cause a respiratory infection. It causes atypical pneumonia because symptoms are milder than normal, but they also last longer and appear differently on a lung x-ray. They are treated with antibiotics, and that's the cause that some of these patients react to. They react to the antibiotic that treats the Mycoplasma pneumonia, so that reaction causes Stevens-Johnson syndrome, which can lead to 10 if it's not treated. And then the mode of transmission for Mycoplasma pneumonia. It spreads from human to human, and it spreads through contact with droplets from the nose and throat of infected people. It can be nosocomial or transmitted within the hospital. And its contagious period is typically less than 19 days. The epidemiology of toxic necrolysis syndrome. So who it affects individuals who are HIV positive or have a chronic inflammatory disease are much more susceptible. Anybody can do it if they have a reaction to antibiotics, but these individuals with HIV are much more likely to get it. The number of people affected, it affects 1 to 6 people out of every 1 million every year globally, but it also affects 1 person out of every 1,000 of the HIV population.
So now we have treatment. For prevention, there's no vaccine to prevent the infection of Mycoplasma pneumoniae, so proper hand hygiene is the best way. Another way is to determine which med caused the reaction and avoid using it in the future. Treatment. Treated in a burn unit as their skin resembles a burn to avoid infection. They give IV fluids and salts in order to replenish fluid lost through damaged skin. And if infection occurs, they are given antibiotics. They give corticosteroids to reduce swelling, itching, and redness. And they may give immunosuppressants to weaken the immune system and stop it from attacking itself. A reoccurrence of 10 could be more severe and life-threatening. So looking ahead, the Christian response. If you see someone who has this condition, we don't want to judge them by how they look. We need to love our neighbors and treat them how we would want to be treated. Another way that Christians can respond to this disease is pray for individuals who are affected with 10 and their families, as this is a very serious and life-threatening illness with a long road to recovery. And then we have recurrence. So avoid using any drugs used 4 to 30 days before the onset of the infection to avoid reoccurrence. So patients should be advised by their doctor to avoid re-exposure to the suspected drugs. A detailed drug history is very important for these patients to take. So any drugs that they use 4 to 30 days before the onset of their infection is good to know and keep a detailed record of, so you can avoid those drugs from then on. Duration of treatment before onset, that's typically 4 to 30 days, and an absence of prior intake, and use a drug known for being associated with a high risk. Future solutions: continue researching ways to prevent this reaction to antibiotics, and then develop better treatments for this condition. Right now, they just try to manage the condition and treat the symptoms, but it's important for us to research and find prevention and just better ways to live with this disease. There's also find ways to help new skin grow back faster in order to reduce the risk of infection.
All right, and then these were our resources.